My name is Dr. Steve Bartels. I'm a geriatric psychiatrist. I direct the Dartmouth Centers for Health and Aging. What you'll be seeing over the next few minutes are several examples of curbside consults intended to help you in managing Alzheimer's that comes into primary care settings. The first will be early Alzheimer's, the second will be a case with mid-Alzheimer's, and then late-stage Alzheimer's. We hope that these will be helpful to you in thinking about how to practically manage your patients.
Hey, Steve.
Hey, Ellen. How you doing? How's the family?
Terrific, thanks. Do you have
good.
a minute?
Sure.
I wanted to talk to you about this case that I'm seeing tomorrow. And I got my IDH message from his wife, who's pretty concerned about his memory. He's a 72-year-old guy, has a history of hypertension. He had an MI about 5 years ago, well-controlled diabetes, some osteoarthritis. He's a retired accountant, had his own practice. He's pretty mild-mannered. His wife's a retired teacher. They own their own home. They have one son. And so his wife said that over the past 6 months or so, he's had some real difficulties with finding his car in the parking lot, some kind of word-finding difficulties. He seems to not remember to pay some bills, which is really not like him, being an accountant. She said he's just not himself. And of course, she's concerned about Alzheimer's, which I think is appropriate.
Right.
So I'm hoping you might be able to help me to think about tomorrow's visit and what are some of your recommendations specifically for screening?
Sure. Well, in addition to the cognitive tests, there's some clinical things we'll talk about, I guess, in a couple of minutes. But if the question is about the screening, there's several instruments that we generally use. And one you may know about called the mini-cog. It basically consists of giving someone 3 words to remember, making sure they have recalled them immediately, and then have them draw a clock, and then have them recall those 3 words. We generally don't use that in instances where you've already identified a problem like you have with Mark. That's more useful in things like the Medicare wellness visit when you're really doing something that's kind of a standard, very brief screen. The other ones we tend to use more when you're in a clinical setting with someone who's got an identified problem. One is what's called the SLUMS, which is the St. Louis University Memory Screen. Another is the Mini Mental State Exam that's been around a long time, you probably know about. And then there's also a thing called the MoCA, the Montreal Cognitive Assessment. So those are, and they're all pretty much the same. They pretty much do the same things and have some good cutoff scores.
So which do you prefer, Steve? Are you concerned about evaluating specific domains of cognition, and that's what prompts you to select a specific test?
Actually, I kind of like the MoCA. I have a slight preference for that because it's actually very clear, and it's got clearly identified categorical functions. It looks at the visual spatial functioning, executive functioning, naming, memory, attention, language, abstraction, delayed recall, and also orientation. And so that actually is useful because it, first of all, seems to be a little bit more sensitive for some of your patients who may have MCI, mild cognitive impairment. But in this instance, it may be more helpful in identifying the types of problems that he really has. And it sounds like you're describing a number of them. But for example, we think broadly about amnestic and non-amnestic Alzheimer's, where amnestic tends to be more focused around recall of recently learned information. And the non-amnestic tends to focus on language and word finding and visual spatial abilities and executive functioning. So I'm not sure which he really has, but the fact that he was an accountant and that he's having trouble balancing a checkbook and he's had some of these other things is really worrisome.
And what other tests should I be administering tomorrow, thinking about some reversible causes of dementia?
Sure. Well, in terms of easy screens, you're familiar with the PHQ-2 and the PHQ-9, and we recommend doing that again if you haven't done it recently, because clearly, as you know, depression can look like dementia sometimes because of the concentration issues. So make sure he's not depressed, and that can be a reversible cause. Make sure to do a physical and neurological exam, which I know you're going to do. Look for lateralizing findings or anything that may look like an indication that he's got something medical going on that might be significant. And then in terms of lab tests, it's pretty much the standards. You want to make sure that you've gotten a CBC and lights, BUN, creatinine, LFTs, B12 and a folate, and then also get a thyroid screen. And if he hasn't had an HIV, make sure he's had that on his records. And then, think about his meds. Wonder about whether I don't know what he's on in terms of meds, but whether there might be some sort of pharmacological interaction or whether or not he's drinking. We often forget to ask that, but that can sometimes look like cognitive impairment that's progressive if he's in trouble with that. So those are the major things. Some people, increasingly, we're probably going to get to the point where we're probably going to do genetic testing, but it's not quite there yet, in terms of commercial use, except for those individuals who have really early onset Alzheimer's, for which we really recommend you probably do genetic testing.
And what about any brain imaging, Steve? Do you do that across the board with every patient that you suspect has Alzheimer's?
Yeah, I think there, we don't do it across the board. First of all, if there is the presence of some sort of lateralizing finding on your neurological exam, obviously you should do that. So if he's got, if he's had any history of TIAs, or you think there's something progressive, or perhaps in particular if he's got lateralizing findings, weakness on one side or the other, or sensory loss, or things that would make you worry about any sort of mass occupying, lesion, then I'd go ahead and do it. But in general, neuroimaging only detects about 5% of cases that you're not otherwise going to detect on a good physical exam looking for those sorts of signs. So by and large, if they got a clear progressive course that looks like Alzheimer's and all these things are present, then probably not necessary.
So tomorrow during my visit, if I do all the testing and I rule out any other causes, and we're thinking that this is early Alzheimer's, what should be my next steps with Mark and Jill?
One thing to think about before we clearly make the diagnosis of Alzheimer's is the fact that he's got vascular risk factors. So you mentioned that he's got hypertension, he had an MI, he's got diabetes. So the first thing to wonder about and go back with the family is make sure that he didn't have something that looks more like a stepwise progression in terms of his cognitive impairment and memory losses and things that he's got, because that would more indicate that he's got a vascular dementia. And then the issue is really around really controlling those vascular risk factors. What you've told me is it sounds like it's more kind of this gradual, insidious, progressive deterioration. That's more consistent with Alzheimer's. So if you get to that point in terms of confirming the history, then really the primary goals are to really improve quality of life, maximize function, make sure that you focus as much as you can on eliminating things that might diminish his ability to have at maximum cognition. So if he's taking any anticholinergic agents, get rid of them. Particularly if they're over the counter, things like that he takes for sleep, bad. Make sure those are off the table. Look at whether there might be any sort of pharmacological interactions of meds he's on, whether they're psychotropic agents or whatever, and make sure that that is considered. And then do your best you can to kind of manage the comorbidities he has that might also affect his functioning overall. Make sure that someone's helping him to make sure that he's taking his blood pressure meds, because he's going to get more forgetful. And then exercise, diet, and then dealing with the family caregivers to start, and him, about what it means to have this diagnosis and the adjustments they're going to have to make, referring them to an Alzheimer's support group. The website from the Alzheimer's Association is really also very good. And then finally, if you don't have it already on the books, this is a really important time to recommend advanced care planning, because this is the time where he's able to exercise decisional preferences around what he wants in end-of-life care. And so to designate a healthcare proxy and think about his choices, what he wants, it's a good time to start to get things in order while they're starting to plan around how to help him to continue to be as functional as he can as this progresses.
And what about medication, Steve? Sometimes that's something that I think is really a challenge in primary care, is to know, what the latest evidence is on starting a cholinesterase inhibitor.
Well, I think it's appropriate as a trial. I think it's an empirical trial. It's an N of 1 trial where you're going to you start him on something like donepezil, which has been around a long time, and it's reasonable, although the expectations should be very modest. That the effectiveness of these agents, as you know, are not wonderful. In some instances, though, in about up to 25%, you see some slight improvement, or certainly some decrease in the rate of decline that occurs. And particularly they can be helpful, in instances where you had, for example, Lewy body dementia or Parkinson's dementia, where there's more of an advantage. But in this sort of kind of Alzheimer's type dementia. Could be helpful, worth a try. And if you don't see, and you increase the dose, gradually and slowly, but look for nausea, look for vomiting, look for diarrhea, sometimes muscle cramping, things like that can be a problem. Can also consider adding vitamin E, at 2,000 international units a day, and then maybe increasing it up to 4,000. And then finally, you can also consider either replacing or augmenting with memantine. As you know, that works differently. It's not a cholinesterase inhibitor. It's an NMDA antagonist. So those are the things. So I think it's worth a try, but modest expectations.
Thanks, Steve. This has really been very helpful. I appreciate it.